Let's moving to the next session. I think you just heard the previous session, but we go to a little bit complicated topic, which not many, including myself, that comfortable in managing the uveitis. So it's called as the topic. The session of this topic is Frontiers in Uveitis, related to innovations and insights into uveitis and thing. So I have the privilege of having Professor Kwan Dong Wen, my mentor, as my co-chair, and Professor Kwan and myself, Dr. Rupesh, will be chairing this session. Dr. Dennis Lam has sent his apologies for not being able to come. Dr. Vishali is chairing another session, so she will just come towards the end of it. There will be small changes in this. So Dr. Pezing Yang could not get his visa. He is not able to come, but he sent his recorded talk. And Dr. Dennis Lam has sent his apologies. His talk is not there. So you have 4 speakers, and then that gives us some time for interactions and all. So I request Professor Kwan to introduce and invite the first speaker.
Coming from Singapore, we have Dr. Zheng Ting, who will be talking to us about the imaging modality for uveitis. Zheng had done a lot of work since he returned to Singapore and had done successfully helped many patients. So today we will learn from him how he used imaging in managing his uveitis patient.
Good morning, everyone. Thanks for the organizers for the invitation to speak on imaging modalities for uveitis, current perspectives. So in the next 10 minutes, I will try to illustrate some of the thinking I have about imaging in uveitis and how I think it has helped me in my practice and in my patients, and hopefully you'll find the same too. No conflicts of interest. So the first question is, why actually is imaging necessary in uveitis, correct? We always try to rely on our clinical history as well as our clinical examination. So let's just take the most common example and the most sight-threatening complication of uveitis, uveitic macular edema. So I would say no one here would now diagnose uveitic macular edema without an OCT. But when the OCT was a novel instrument about 15 years ago, people have actually done studies and realized that ophthalmologists were missing up to 40% of macular edema and misdiagnosing another 17% of patients with macular edema. We now have great tools with our machines for longitudinal follow-up. This is the Heidelberg Spectralis platform. You might be using Topcon, you might be using Zeiss Retinal Workplace, but these shows how powerful it is for longitudinal follow-up of disease progression and treatment efficacy. And related to that, you can understand a picture speaks 1,000 words and how important it is, especially uveitis being a chronic disease. A tool like this can be used for patient education as well as medical legal documentation. Lastly, looking at research, we know that uveitis clinical trials are besieged by subjective outcome measures like visual acuity, vitreous haze. Imaging may help us try and quantify these areas. So let's go into some of the thinking I have about imaging. Firstly, we have multimodal imaging available right now, and I often think of imaging in 2 ways, structural and functional, and I organize them in a step-ladder approach from the most available, cheapest and repeatable to those that are slightly more invasive. You can appreciate here the case for ultra-wide field imaging. On your right, you see the 200-degree field of the Optus camera. There are other wide field platforms like the Zeiss, and this is compared to your direct and indirect ophthalmoscope as well as your 90-degree slit lamp. You will understand in uveitis we have many patients who are uncooperative, pediatric patients, dense cataract, small pupils, posterior synechiae. So you will feel how easily it is to miss things if you do not have wide field imaging. On your left, you see relatively normal fundus photographs, but the angiogram shows highly active posterior uveitis, right? This is a situation we all face. And these 2 studies actually show that with the addition of wide field color fundus photography as well as angiograms, up to 3 times or 5 times the number of patients have their disease assessment changed and management subsequently changed. So my take is that if wide field imaging is accessible to you, do consider using it. So from the peripheries, we go right down to the posterior pole, something that we all feel is easily accessible, easily accessible as well. On your right, you see a list of causes of reduced and increased autofluorescence. And I think autofluorescence is a great tool to assess the posterior pole when the patient is complaining and we see nothing. And these pathologies generally lie in the outer retina or the superficial choroid. So let's go into some case examples. This is a 30-year-old male who complains of visual disturbances after a bout of viral infection. You can see the Zeiss color photo on the right, on the left eye, essentially normal. But on the autofluorescence, you see the dots and spots in the parafoveal region, typical of Mute's disease. This is another young lady, 42-year-old. If you are really astute with your 90-degree diopter lens, you may argue that, oh, this right retina looks a little bit pale, the vessels look a little bit attenuated, the sheen is not there, the choroid looks a little bit more apparent. But on the autofluorescence, you really see this mixed granular hypo autofluorescence in the peripheries, only sparing the central 10 degrees of the fovea. This patient eventually was diagnosed with autoimmune retinopathy. Just one more. So again, a relatively normal color fundus photograph of a 50-year-old lady complaining of flashes and floaters. But on the autofluorescence, you see this annular hyper-autofluorescence around the disc extending towards the temporal arcades. Eventually, this patient had an ERG and was diagnosed with APSOII. This is one of my favorites, VKH, something extremely common that we can see in our own practice. I think you will agree with me that the autofluorescence photos really demonstrate the extent of the exudative retinal detachment far better than the color fundus photos. So consider using this. So we have talked about the peripheries, we have talked about the macula. Now, not only describing the physical changes of the eye, we also need to continuously upgrade ourselves and understand what the imaging is telling us. And here I would like to speak about OCT biomarkers. This diagram shows you how far OCT has come. Right now, OCT is an instrument that can enable us to image from the vitreous all the way down to the choroidal scleral interface. And there have been much work by very intellectual people in these fields trying to give clues to the etiology of uveitis patients through OCT biomarkers. From the infectious portion, you have the pre-retinal as well as retrohyaloid deposits that try and differentiate between toxo and viral retinitis. Here again, you see the choroidal involvement in A and B panels, signifying a more likely toxo cause as opposed to C and D, with the choroid relatively spared and more likely viral retinitis. Here you can see the rain cloud sign in fungal endophthalmitis. And not only infectious, but also in inflammatory uveitis, the bacillary layer detachment that has been described first in toxo, but now realized to be most common in VKH, and is a good differentiating sign with CSCR. Here you see the sign described by David Seraf's group, the ASH sign in MP. And lastly, if you look at the fundus photographs of these patients, one might be not faulted to think that this is viral retinitis. But if you look at the OCT, it demonstrates rounded roof appearance, infiltration of the inner retina, and outer retina undulation. This patient was eventually diagnosed with primary vitreoretinal lymphoma. So there are newer developments on the horizon. No talk about current perspective can leave out the debate between OCTA and dye-based angiograms. I am not going to that because I'm not an expert, but I will refer you to this excellent editorial which people have written to try and allow us to understand the place of these two imaging modalities in our practice. Moving on, automation is a big thing now in ophthalmology and all of medicine. So people have also tried to use machine learning and artificial intelligence to quantify AC cells and vitreous haze. All these will probably serve to strengthen the need for imaging in our future uveitis patients. So in summary, I leave you with 4 points. The first is that nothing can replace a good history and a physical examination, but stepwise imaging is probably necessary in this day and age for our uveitis patients. If it is accessible to you, do consider ultra-wide field color fundus photography and angiograms because they tend to pick up much more lesions and change management as compared to the traditional 30 to 55 degree views. We also need to continuously upgrade ourselves because imaging biomarkers have shown that it can clue us in on various etiologies of diseases. And lastly, future developments in the imaging sphere will probably serve to make multimodal imaging more essential in uveitis practice. I thank you for your attention.
Sure. there are some chances that there will be some overlap between the different speakers and the talk. So what we'll do is we'll keep the questions in the end, so that we let the other speaker cover if something you feel you wanted to ask, so that you see hear through the entire presentations from all the 4 5 speakers, and then you can come up with the questions. So we want you to kind of, because these are all extended and a lot of overlap will be there. Now, before we go on to the live talk, we'd like to hear from Dr. Beijing Yang, who is the world leader in Uveitis in China, and he will be giving a video recorded talk. So let's hear from him. Can you play the video session, please?
So Professor Yang from Chongqing University in China really make an effort to come here. However, the relationship between China and India had led to him unable to get his visa, so he's apologized very much because he was planning very much.
My name is Lin Yu Dai. I am a graduate student of Professor Yang. My presentation is Advancement in Uveitis Imaging, a comprehensive overview. Uveitis is an inflammation involving the uvea, retinal blood vessels. Its diagnosis relies not only on clinical manifestations, but also on ocular imaging. In recent years, advances in multimodal imaging has significantly contributed to the management of uveitis. Multimodal imaging includes lots of ocular imaging, such as fundus photography, fluorescence angiography, endocorneal green angiography, and optical coherent tomography. Multimodal imaging could detect the ocular chains and the complications of uveitis, such as macular edema and retinas. Multimodal could be used to assist in diagnosis and differentiate diagnosis. It can also be used to monitor therapeutic efforts. The most significant developments of imaging include the use of OCT. TD-OCT is an earning OCT imaging technology with low resolution and slow acquisition speed. FD-OCT technology replaced TD-OCT in the 2000s, realizing micro-level resolution and real-time high-definition imaging. FD-OCT includes SD-OCT and SS-OCT. It drives OCTA for non-invasive visualization of fundus hemodynamics. There are some differences between SD-OCT and SS-OCT. SS-OCT has a longer wavelength and a greater penetration than SD-OCT. SD-OCT is less expensive and more generalizable than SS-OCT. SD-OCT is more commonly used for retinal imaging. However, SS-OCT provides a clear visualization of deeper structures, such as the choroid. SS-OCTA provides non-invasive imaging of retinal and choroidal vessels. It is a technology developed based on SS-OCT. It offers standardized image analysis, such as vessel density qualification of layers of fundus and fovea, a vascular zone area. It has a great penetration to clearly visualize the retinal and choroidal vessels. Actual wide field imaging captures more than 80% of the retinal area. It can provide an imaging range of 200 degrees or more. It can detect peripheral vasculitis or slow ball-like clotting in uveitis. Panoramic view provides dynamic monitoring of disease progressing. FA can directly visualize vascular leakage. It can display diametric vascular leakage. It is sensitive to recognizing uveitic retinopathy in the early stage. FA focuses on the retinal vascular wall. ICGA focuses on the choroid. The two are complementary rather than substitute tools. Recently, our studies has focused on OCT and OCTA. Next, I will briefly introduce our finding in uveitis by using OCT or OCTA. EDI-OCT can detect retinal vascular change in VKH. We found that VKH patients with poor visual prognosis had vascular pruritus lesions in the retina detected by EDI-OCT at 12 months following treatment. The vascular proliferative lesions were formed at 3 months following treatment. SSOCTA is a useful technique in detecting non-vascular lesions in patients with VKH. We found that patients with high accuracy VKH disease exhibit new vascular lesions around the equatorial retina by wide field SSOCTA. SSOCTA could assess the effects of early and late treatment on choroidal retinal microvascular in VKH. We found that VKH patients who are treated within 2 months of disease onset showed a better choroidal retinal microvascular outcome as compared to those treated late. Sensitive SSOCTA parameters could detect retinal vascular alterations in basis uveitis. We found that floor area and visual density of deep capillary plexus were apt to be affected in basis patients. The paraphobia and peripheral flora of deep capillary plexus parameters were more sensitive to sensing subtle microvascular alterations as compared to other SSOCTA parameters. SSOCTA can detect ischemic retinal lesions in patients with basis uveitis. We found that patients with quiescent basis uveitis who had good central vision exhibit ischemic lesions in the peripheral retina by SSOCTA. With the development and advancement of technology, the integration of artificial intelligence and imaging is becoming more and more close. AI algorithm can automatically detect and qualify inflammatory lesions in uveitis. AI can be treated to recognize specific patterns and features of different types of uveitis. Machine learning models can predict treatment responses based on imaging factors. This is our recent study by combining OCTA and artificial intelligence. We utilized an OCTA radiomics approach to establish AI models for the biomarker development and automatic prediction of basis uveitis. We found that the radiomic score and the clinical integrated score can independently serve as diagnostic biomarkers for basis uveitis. In conclusion, advanced in multimodal imaging has provided more accurate tools for the diagnosis of uveitis and improved the precision of treatment. The combination of imaging and artificial intelligence has demonstrated a great potential for application in uveitis diagnosis and treatment. That's all my presentation. Thank you for your listening.
So, on behalf of the committee, we thanks Professor Yang and his team of students and interns to present this thing and give a little bit more extra insights than the first speaker. So, we are a little more knowledgeable, but let's make us more knowledgeable through the third speaker, who is none other than Professor Kwon Dong Wen, who has been the mentor for many of us sitting in this audience, including myself and my academic and my professional and even my personal mentor as well. And with that, I invite, and he is a professor in Stanford University from Bioscience Institute. He's going to speak to us about concept of metabolic imaging, insights into uveitis and retinal vascular disease. So we look forward to hear from you. Thank you, Prof.
Thank you, Rupesh, and thank you everyone for joining us. I'm going to discuss something that's probably very new to many of you in an audience. If you were here yesterday in the uveitis session, one of our colleagues, Dr. Jia Hunt, had discussed a little bit about this concept. So I'm going to bring you things. This is called metabolic imaging, how we can consider that for various retinal diseases and uveitic diseases. This is to look at how the change in metabolism of tissue, just at the retina, that can help with that aspect. By the way of disclosure, our University of Stanford has received research funding from OcuScience, the manufacturer of the system that I will discuss. So many of us are here now in daily. Certainly, among the diseases that we try to conquer and help are leading cause, for example, macular degeneration, glaucoma, diabetic retinopathy. These are things that many of us are trying to fight so to make sure we preserve the vision for our patient. Certainly, uveitis is also among that group because it is the fourth leading cause of blindness. The number here, 20 billion, that's a very large amount, and that's just in the United States alone. If you look at it in a global worldwide, that would be a tremendous, very high amount of money. I would think that all of us do believe in the concept of early detection. For any disease that we discuss, it will be good if we can detect the disease early so that we can have timely intervention, we can reduce the cost to this aspect, and we can improve outcome. For example, certainly in diabetic retinopathy, that has been the concept, and we want to make sure that we prevent so the disease won't get worse, so the patient will not suffer from diabetic ocular complication from that. So this is the same concept in him that we would like to do. During the past few years, the pathway to mitochondrial dysfunction of eye disease had helped us to understand further the pathophysiology of diseases such as diabetic retinopathy, macular degeneration, as well as glaucoma, to the fact that many of these conditions start out with, after the certain factor, for example, hyperglycemia or aging, lead to oxidative stress and then mitochondrial dysfunction from that. What about uveitis? And certainly that's the topic that many of us are also interested in. Let's look at the mitochondrial stress. This can lead to apoptotic cell death, underlying pathology in a number of ocular diseases. However, prior to the cell death, which is apoptosis, mitochondria exhibit what we call impaired electron transport that can then lead to an increased oxidation of flavoprotein. So it is this concept of flavoprotein that we now focus on. The Ocumet beacon, which you will see shortly, is a device that measures the redox state of flavoprotein in the retina, and it helps us to detect the health of the retina, among other things. This is a cartoon that's showing what happened from the beginning. Oxidative stress lead to mitochondrial flavoprotein being produced, increased native fluorescence, and potential clinical metabolic abnormality. As you can see, there's a reduced flavins, and then when they activate, that's an oxidized flavin that we now try to measure with this aspect. Where is the mitochondria in the eye? So they actually look in different parts. On the left-hand side there, you would see the presence of mitochondria in the retina there, and on the panel B, that's where the stain using the vitamin C oxidase. On this panel on the right-hand side, between non-stain and stain, you can also see the presence of mitochondria in the optic nerve as well. So we know that in different parts of the eye in this aspect. The concept here is that we recognize that when the cell undergo mitochondrial stress early in the disease and before they commit to apoptosis, this is very important. The cell dysfunction, mitochondrial dysfunction, occur very early before the so-called apoptosis or cell death. So we definitely want to catch the disease at that stage. Most current retinal imaging, such as OCT, only show the structural abnormality of advanced disease. If you look at the scale on the bottom, from left to right, you see the mitochondria act in this aspect. That's mitochondrial dysfunction. That's relatively early. Most of the time at this moment, we as clinician scientists will see patients when they have vision loss of visual pathology, and that's where we would like to, right now seeing that. But we want to shift our opportunity. We want to take the patient earlier to see if we can detect it. So with this concept, again, early intervention in disease is indicated to maintain mitochondrial function with this aspect. On the right-hand side, you see a lot of the technology that we at ophthalmologists are using right now. We use fundus autofluorescence, we use fundus photography, the retinal tomography. Many of that corresponding to when visual pathology has already occurred, with blindness occur already. What we would like to see if we can move it more to the left, where we want to detect the disease earlier. So here is where this new device come in and this new technology to look at mitochondrial function as a way of look at the metabolism. So-called the mito4 modality from this instrument can help to assess eye disease earlier. This is the key fact, earlier, and quantitatively measure those diseases over time to monitor the progression. That's what we want, because right now we're more on the right. We want to bring all of us close to the left-hand side so we can detect the disease earlier. This is a very simple cartoon to illustrate to us what we're looking at right now. Right now, certainly all of us are familiar with OCT. This is the reflected beam from the instant beam going to the eye, reflected beam coming out for fundus images. When we talk about other technology, for example, when it's involved absorption of light, and that leads to, for example, fundus autofluorescence, and then this product, fundus protein fluorescence, and the FLIO, this aspect here. So that's a very simple concept, how we distinguish this from other aspect from there. This is the device. It's called the Ocumus Beacons. It's one of the latest technology that we are now enhancing to assess the retinal tissue aspect. So the light, the blue light will go in with the green light emitted out. That's what we capture from that. And then it's generated for us. We gather the data, we then synthesize the data, analyze it, and then generate a report, what's so-called the FPF score, and we're between 15 up to about over 100, depending on disease status of this aspect from there. On the left-hand side in that box, we have also the diseases that have been tested: diabetic retinopathy, AMD, pseudotumors, central series retinopathy, retinal dystrophy such as Stargardt, primary open-angle glaucoma, because it's also capture how the optic nerve function. So in this type of condition, when this oxidative stress, before the setup occurred, we will see an increase in the fundus protein fluorescence of this aspect, and that's so-called FPF for this aspect. That's what we are detecting. This is a recent study that looked at over 450 eyes with this aspect, all have different stages of macular degeneration, from early to intermediate to geographic atrophy to neovascular AMD, to compare with the healthy control. So basically, this particular study looking at what kind of appearance on the FPF for a number of this type of neovascular AMD or GA or different thing. So they showed that the different type of AMD, different stages of AMD will have different FPF imaging, as you can see from the lower level there. So based on that, they are now using that type of FPF to monitor the patient before any other invasive techniques will be done to do that. What about, obviously, as clinician scientists, we also like to ask the question, so pictures are beautiful to look at, but how functional are they? How good can they be, and what can we do to understand how to use it? Just like when Dr. Ting showed earlier today, when we were using wide-angle imaging, it's nice to look at image, but how functional it is, what can it do to help us in the clinical management of the patient, and that's the most important part. So in this particular case, we also see how it's functioned, among other things, diabetic macular edema. And this is a case of a patient with significant macular edema from diabetes. At day 0, when this, you can see from there, in that aspect, because of the presence of macular edema, the clinician decide to inject triamcinolone to this aspect. So within 1 week or so, you would see a reduction in the FPF about 7%. So you can look at the beginning about 88, and it go down to about 1 week later to about 82 aspect from there, so about 7 points from there. So at this moment, because of the way different clinicians follow different patients and things, so at this moment, we decide to add anti-VEGF, any particular type that you like, and then you follow the patient for about 3 months later. Here, you now can see that the FPF actually now reduced now to about 24% in this aspect from there. So we do see that this aspect. And so you say, so what? We can also see in OCT as well. But here's the point with this aspect. All of us know who manage patients with retinal vascular disease like diabetic macular edema know that OCT is not always predictive of visual acuity, and oftentimes OCT change, we see it first, and then subsequently we will see changes in the visual acuity because it lagged behind. So one of the questions we asked is that, can this FPF help to predict visual acuity earlier before? So would you decide when should you continue to treat an eye, for example, or is it already get to the point where it's futile? No matter how many more injections you get, how flat you get the foveal center, it will not make a difference. So in this particular case, it seemed to be that the FPF seemed to correlate with visual acuity improvement better. And in fact, FPF may detect the metabolic improvement before the structural improvement occurred. So this would be very helpful in the case where you would decide whether or not you should or should not move forward to treat with additional aspect from there. And here the FPF mirror the visual function change seem to be better than OCT thickness than that aspect from there. And again, this might be able to help us as a tool that we as clinician scientists will be able to do with this aspect. So now what happened in uveitis? This is a field that many of us in the field very much attached to in this aspect. So could FPF serve as a biomarker for early detection of inflammatory activity? So we will show you 3 cases, and I'll see if I can explain this. This is the work done by 2 of our current fellows, that Mohammed and Amir. Some of you in the audience may recognize at least Amir in this aspect from there. And this is the work that has been gathered by the team in this aspect, because this is the first time that this type of FPF was actually being used and to manage to monitor uveitic condition. So we start with 2 cases. This first case is A29 associated, so you may cause birdshot. And this is a patient that we, using various functional endpoint and also using some of the imaging thing, decided this patient had very aggressive condition. And as you can tell from the treatment, we were using adalimumab 40 milligram every week and also put methotrexate on that too. So right away when you look at regimen, you know that this patient received more than the typical dose of that. And so we has determined that this patient had Graves' disease. So the upward, you see the ICG and you see multiple hypofluorescent dot in this aspect. And then when you do the FPF, you will see that below there, you will see the number much greater than the 35, which is the upper limit of normal in this aspect from there. So fine. This is the patient, we figure out that the patient have active disease based on functional tests, and we tested that, it is fine. We see the change in FPF as we expected. This next patient also had birdshot as well. However, this patient, so far from our clinical knowledge, we thought that he was stable, that she was stable, so we just keep the patient only on adalimumab every 2 weeks and methotrexate 10 milligram, this aspect from there. So we think that this patient who also had birdshot may have a lesser disease. However, the ICG are shown as expected. But when we look at the FPF, we show that the number actually higher than the other patient. So now, with this additional information, we are pondering to see whether our clinical judgment is, could it be modified further? With this additional information, can you now determine whether you should treat the patient further or not? And certainly we don't know the answer yet because we're ongoing looking at this process right now. The third case is a patient with B51 positive, and this is a patient that you can see from the upper colorful funded photograph. Dr. Tin just mentioned to us that cannot really tell us much, so you have to look at the fluorescein. But you and I, when we look at the fluorescein like this, by the time that we look at the fluorescein, we see significant vascular leakage already, and obviously the patient will most likely have functional loss. So our question is that, can we detect the disease earlier before you see all these changes on the fluorescein? And so if you were to look at the FPF, you will see that the number is quite high. So the question would be, could we able to use this to detect even earlier before the change in the fluorescein angiography? So in summary, what I've shown you is a new concept, at least for the field of uveitis with this, that look at mitochondrial oxidative stress, which is the key factor in many retinal diseases, including AMD, glaucoma, and diabetic retinopathy. And in this case, using this new technology, we measuring damage due to metabolic stress for this aspect from there. And our disease certainly have pre-structural damage in this aspect from there. So finally, we want to find out whether this technology can help us to manage our patient and vascular disease better or not. I do know we have a little bit of time, so that's why I'm taking a little bit longer time to do it, but we make sure we stay on time on this aspect. And finally, it's certainly for me to be able to present like this, certainly I owe the work to many of our colleagues, and this is our current team from Stanford. Some of you may recognize some of these people. We're very proud of this moment, 10 different countries representing right now in our teams this there, and we have great time together with many of our current players. And then finally, if you are interested further in this, please join us in Rio de Janeiro this June. We will have our International Ocular Inflammation Congress. We'll be in there. Looking forward to seeing everyone. Thank you.
So I think that's a very wonderful talk and something, the insight into the future, which might be helping us, some functional imaging, if I can call it as. So we'll move on. I think Professor Vishali Gupta is chairing other sessions. She'll be coming in some time. So before she come,
So Dr. Agrawal come from Singapore, as you know, the leader in many different areas. If you have not heard his name before, you should. He was the leading of the Collaborative Ocular Tuberculosis Study Group. He's also in charge and lead the proton group. Basically, his name is everywhere. Anytime you see inflammation, you think of Rubesh Agrawal from Singapore. So welcome. Oh, you want him over here? Okay.
no, this speaker is not there. She is Vishali Gupta.
So Dr. Gupta is not here yet. She will come shortly. So can we put Dr. Rubesh Agrawal next? Yes.
Thank you. So thank you, Professor Kwan, and thank you, APU, for giving the opportunity. The next speaker for the session, Professor Dennis Lam, has also sent his apologies. He will not be there. So I'm combining the two talks for him as well as in this thing. His talk is on the collaborative efforts for imaging, and my talk is about advancing what has been said by the speakers so far. So there are no conflicts of interest as far as this talk is concerned, and otherwise also, Uveitis people not have that many conflict of interest as such. Not many people fund them. So the challenge with uveitis and why we are gathered here as imaging specialists for the uveitis is that the assessment of inflammation is the key, and we need to really find out from this talk, are there brand new tools or some dedicated tools which will give us an objective quantification of so-called inflammation, and how do we test and rely on some of these branded tools or branded software algorithms and all. So, but whenever we do any of those advances, we need to go back and look into the books. So go back and look into the history. The history is like sun is the standard for uveitis care pathway, whether in terms of nomenclature, and also it has defined the activity of the uveitis in terms of inactive, worsening, improved, remission, all kind of things have been defined by sun. Also, the inflammation in the eye, which we are trying to monitor, because this is what we want to achieve. It is very important that when you are doing imaging, you need to understand what you want to achieve through the imaging. So you want to assess AC cells or inflammatory cells, you want to assess vitreous haze, or you want to assess AC flare, or any kind of inflammation, whatever is happening from front to the back. But these are the three standard guidelines given by the sun about AC cells, vitreous haze, and AC flare. So this is about the AC cells. This is about the flare, which I think all of you know, and different gradings has been there, and then there has been something and some attempt about the vitreous inflammation. So these are the three things according to the sun, and someone was asking me, based on the OCT, what are the signs of active thing you will be able to define. So I don't have a correct answer to it, whether should I call cystoid macular edema or some of those things. We really do not know what are the signs which will tell us based on the OCT or some of the other tests which will be helping us and increase this pool. But right now, these are the three things which has been given in the literature and with which we follow, besides some other things on FFA and ICG and many things. But the challenge with these things are, these are subjective. So what I see, what my friend ZX sees, what my other colleague Dr. Ho Suling sees, we all see probably different, and sometimes there can be grading. It also depends on, I run a clinic in NCID, I'd see 0 cells or maybe 1+, and I come here and see on a hextrite slit lamp and suddenly those cells become 2+. I said on a Takagi slit lamp it was 1+, and another slit lamp it has become 2+. So it is sometimes depend. I switch off the room light, suddenly there are a lot of cells. You keep the lights on, you can't see anything. and then you feel ashamed in front of your fellow is able to pick up the cells, and you as a consultant is not able to pick up because you think you are overconfident and you just no need to switch off the light. So these are the variations which comes into practice, and we need to acknowledge and appreciate that there are variations there. These are non-continuous. You do not have like 1, 2, 3, 4, 5. You have like 1, 2, 3, 4, some steps, but there has not been that many attempts. And you really, from 2 to 1 is okay. Can I change Bradford 4 to 1s or cells of 3 plus to 1? Do you change? How do you change? Because there is no continuous grading of that, and poorly discriminatory and all. So these are the outcome measures which has been used in the clinic and also in the clinical trial. And result of which is inter-observer agreement, treatment guidelines are not very clear, management decision making, a high failure rate, need for more sensitive inclusion criteria, reliable endpoints. So this gives us the background about the imaging. So imaging comes to our rescue. We have already seen about some of the things, and everyone picks up their own tool, own toy. There are so many toys in the thing. I cannot be saying that I master all this toy. So I decided to pick up my own toy in 2012. So with my very dear colleague Jason Lim, who is gone into oculoplasty, probably he struggled with this choroid. So we wrote a small grant in 2011 when that time AIOS2025-GP83 was not there. And I thought we should look into the choroidal thickness. And that was my first ever $10,000 grant, which I got, but could not get anything, only 20 patients recruited, never published. But I was still interested, went to Moorfields, understand that the choroid has much more in this. And there was a software developed by Adnan Tufel, Srinivas Sada, and Pierskin. He given me the software to look into the choroidal vasculature and choroidal structure and all, and I started looking into it. For me, whenever I try to do a bit of groundwork again, understanding about where is the choroid been studied, what has been studied, what is missing out in the literature. So I again went back to the blackboard, understanding about what it does. So we wanted to see, can we divide the choroid and come up with the segmentation and all, and this was my first attempt. We got 20, 30 patients, and I thought, let me check what I can see as a qualitative outcome. So whenever we talk about imaging, it is qualitative and quantitative. So this is a qualitative. We graded these images into retinal parameters for inflammation and choroidal parameters, and these are some of those things. After this, I have never used it. This was only to get a paper published into one of the journal. But I still don't do, but I use it sometimes clinic, but subconsciously because I'm practicing, but I just use it not like I have a checklist and I check mark whether it is there or not there, or binary kind of thing is there. So these are some of those qualitative changes which we need to appreciate besides the quantitative we talk about. But always, because we all love numbers, we always keep talking about how much is the macular thickness in terms of microns, meters and all. I thought we should be looking into a number, and that is why I generated this number of called as choroidal vascularity index. Some of you might be familiar. We wanted to analyze and see how much is the vasculature, and this you can see the segmentation through an animal eyes which has underwent a laser CNV, a laser induced CNV, and you can see the segmentation which was done. So we thought it is a simple non-invasive way to monitor choroidal vasculature, was repeatable, quantitative, proven, cheap. You don't have to buy, you just integrate this into the existing OCT machine and you don't have to buy any separate software. Published many papers to prove. We went to Zeiss, hey, we got the tool, can you integrate into your machine? No. You cannot, because you haven't proven it. Thought, this is not proof? No, you haven't proven it, because we have not used the ARI network, ARI network. I said, no, we don't know how to use it. No, you have to prove yourself. So this is what we proved, but we were told that you have not proven, and then we cannot use it in the clinical practice. So I think they might have some merit, but we continue to publish, and these were some of the publications of choroidal vascularity index in patients with uveitis, whether it is a pan-uveitis, serpiginous choroiditis, VKH, again VKH with another group of patients from India, and in India with Chennai and Bangalore. So we looked into multiple papers, and we come to this particular paper which we are writing now is about the meta-analysis about all the publications on CVI in uveitis, and this hopefully should be coming. This was presented at last year ARVO, and hopefully this will give us some bit of understanding, and this paper will be coming up hopefully soon, presenting about some of the things which CVI can tell us in context of the uveitis. But because Zeiss told us that, hey, you cannot go and do that, we thought we set up our own ARI network, which was Advanced Retinal Imaging Network. We had our own network by that time called as COIN. COIN is Comprehensive Ocular Imaging Network. But when you talk about a collaborative platform, you cannot be just having a choroid. We thought we introduce other measures for assessing inflammation. One was vitreous haze, then we introduced retinal vascularity index, and recently we are launching iris vascularity index, which I'm not going to talk about. But you can see on this snapshot the vitreous haze which can be assessed, the retinal vasculature which can be assessed, and iris. So this has not been proven so far as much as choroid has gone, because this has been done in last 2 to 3 years through different grants. And we hope that if we put all this together, we will be able to come up with better quantitative measure, and therefore we call it as a bit more advanced image analysis. So just to get you a glimpse into retinal vascularity, there has been work done. It's not the first time, and none other than Alexander Invernizzi has done wonderful work during the time of retinal vascular diameter and vasculature and uveitis. So we developed our own software. So this software allows you to pick up arteries and veins, segment it into different calibers, and then gives you an insight into what's happening and give you an artery-venous ratio. So we did that in COVID, we did it in multiple patients, we are doing it in the patients of uveitis to see whether it gives you a difference and at the baseline cross-sectional between the uveitis and non-uveitis, and for a follow-up longitudinal, does it give you a difference, a meaningful change, and are you looking into something better, something different, something with our existing tools like fundus images. So we'll not get into that. There are some results, very preliminary. This is just to show you the work in progress, inactive, active uveitis, control uveitis, longitudinally what happens, trying to validate. So for me, anything which we want to propose, we want to validate it before people in the group or the community of general ophthalmologist or uveitis specialist can use it. So that's what something which we are trying to do. So we'll quickly jump to the last part of this talk, which is the vitreous dot index. And this is again a tool in progress, and we are pretty confident this will give us a very strong measure which FDA is looking for, looking into the vitreous haze. So this work done based on the sun, the different images, then there is a Zenith Davis score also, and there have been attempts to do it. But what we did is segmentation of the OCT images, manually picking up the vitreous, then calculating the vitreous cell density or the vitreous haze density. So this is the segmentation of the OCT, then calculating the vitreous cell density, then haze density. And there have been work done by, first was done by Piers Keen, but mostly this work was done by Tariq from Manchester, and he wrote the software which was further validated by Piers and Alistair Denniston. And we try to use that software with the images from Centon after getting the approval for one of the studies, sirolimus, but we were not getting very promising results. And then we thought of developing our own software. So my own current software, I think we'll come to that quickly, is this, which allows you to segment the vitreous into the posterior vitreous, mid vitreous, and anterior vitreous. And there is a logic why I divided the vitreous into this hypothetical zones of posterior, mid, and anterior vitreous. And then we were able to quantify the vitreous cell inflammation in any of these 3 bands of the vitreous, telling us that vitreous cell density can tell us, and we are coming up with the publications. And we, one of the attempts which we want to do under this study is we want to compare with the vitreous hemorrhage as well. Can we differentiate using the OCT vitreous hemorrhage from vitreous inflammation? I don't know, but we are trying to make an attempt and see whether we can do it or not. Once again, these are all work in progress. Please don't go and use it and quote me and that Dr. Rupesh has said this in this thing. But these are all things which we can think as a researcher and all. So what are the applications of this? It can help us define and progress and all. But eventually with the goal which all of us want to achieve is a biomarker to use it in our clinical practice by every single person, not just sending the images to a image reading center and then they tell you, you cannot, your patient cannot wait. You want to take a decision there and there itself. Therefore, this tool need to be integrated into your OCT machine. Whether it is CVI, whether it is vitreous, whether it is retinal, has to be there, accessible to you, and then up to you, how do you want to use. So this is where we want to see this biomarker or advanced imaging analysis to be coming and hitting our clinics and helping us manage our patient. With that, I'd like to thank you for your patient listening, and thank you very much.
Great, thank you, Rupesh. And so we have one more presentation, and then we go into discussion. So from Chandigarh, India, we welcome Professor Vishali Gupta, a very, very significant leader, well known throughout the world for her expertise in both uveitis and retina. and she will share with us her expertise in imaging biomarker for infectious uveitis. Vishali?
Thank you, Kwan and Rupesh, for giving me the opportunity. So the topic that I shall be talking about are what are the imaging biomarkers which could give you a clue that you have done imaging and what you are dealing with could be a possibly infective pathology. So let's start with the vitreous. Now, as this arrowhead indicates, you could have the precipitates, inflammatory precipitates sitting on the surface of the retina. So if you have these deposits, think of infection as a possible cause. So they may be on the retinal surface or posterior hyaloid, and you see them commonly in toxo, sometimes in herpes and syphilis. Now, are there any specific biomarkers between toxo, viral and syphilis? Well, this is what toxo pre-retinal precipitates would look like. You will have these oval deposits on the surface of the retina, or you may have these round deposits on the posterior hyaloid, and you may see the mirror imaging. Like there are deposits on the hyaloid, on the surface, they are kind of as if they are getting reflected. And you may have retrohyaloid hyperreflective dots. If you see any one of these, think of toxo as a possible etiology and then look at the choroid. Is the choroid involved underlying? For example, this is a patient which has the retinal involvement, but there is underlying involvement of the choroid, which is kind of a very strong biomarker that what you are dealing with is toxoretinochoroiditis. When we talk of viral, here when you look at the posterior hyaloid, it appears thickened. There are some hyperreflective tracts like you see with these arrows, but you do not see the round deposits like you were seeing in toxo. Now I would have gone back to show you the round deposits of toxo, which are very different from the thickened hyaloid and tracts of the viral. You may have a variable degree of vitreitis, which is seen in majority of the viral, but you will not have any choroidal involvement. So that will help you differentiate toxo from viral. You can see here, there is no underlying or very minimal choroidal involvement. You don't see like in toxo. So the top represents OCT in toxo, which has pre-retinal deposits, retinal involvement, and underlying involvement of the choroid. Whereas the bottom is retinitis of viral. You do have lots of cells, but the choroid is relatively normal because viral is retinitis, toxo is retinochoroiditis. Then we come to another masquerader, which is syphilis. Syphilis, sometimes, when you look at the patient has scotoma, but, you may just pass it off as normal. Never ignore the patient. He does have scotoma. And here is the autofluorescence. Autofluorescence beautifully shows this whole area of placoid involvement of syphilis, which sometimes may be too subtle to be picked up even on clinical exam. OCT is very important. The multiple pre-retinal dots, which you may see here, RPE irregularities and the loss of ellipsoid zone. For that, it's very important that you do OCT over the lesion, not OCT through the macula, which most of the techs do. So take the OCT through the lesion, and if you see the loss of ellipsoid zone and RPE irregularities, it has a very high diagnostic predictive value for syphilis. So syphilis test sometimes could be false negative, but if your imaging is indicating, it's important to repeat them and do both treponemal and non-treponemal test. So this is the presence of, again, you can see these lesions, loss of, you can see here the ellipsoid zone, it just gets lost, and the RPE irregularities. This is something you will see in syphilis. This patient had both the test positive and was also HIV positive. So the third sign which should not be missed, which is very typical for infective, is the rain cloud sign. So you have to remember that howsoever severe retinochoroiditis may be, it will have the overlying cells, but you will not see the cells bursting out of the retina. For example, this patient, you see, this is actually coming out of the retina, this is endophthalmitis. So if you see this kind of a rain cloud sign, be very, certain that it's going to be infective, and this is not one of the non-infective uveitis, and it's important because then you don't give steroids, then you try to find out the cause. We work in uveitis, and we all know that we are kind of strange people who confuse lymphomas with toxos and viral, and we all have done it at some stage or other in our lives. So are there early biomarkers? Yes. So this is kind of a diffuse picture. You can see it could happen in quite a few of cases, but this particular patient had lymphoma. So if you get the OCT through this and you see the rounded roof configuration like the arrowheads are indicating, or you see hyperreflective disorganization of the layer, and most importantly associated with subretinal or sub-RPE infiltrates. This is very highly important biomarker for a possible malignancy, because sub-RPE infiltrates are something which lymphoma very classically produces. This is another example to show you the rounded roof configuration, disorganization of the layer. So these are the biomarkers which I already kind of showed. Then we move on to the inner retina signs, and when we are in the inner retina, besides the infiltration, you could also have foveolitis, and this foveolitis here is different than what I showed on the rain cloud. Rain cloud is bursting into the vitreous, you think of endophthalmitis. When just fovea is elevated, this is foveolitis, which you could see in dengue or other post-fever viral retinitis. So we have published this, which I'm not going to, but these are the kind of the patients who respond to steroids with the restoration to normal. Another important sign, and this is very important, is ILM drape sign. This is an 11-year-old boy who comes with decreased vision in both the eyes, and which is reduced to counting fingers, and very rapid onset, and it's a very dramatic. So when you see here, there is loss of retinal layers, and ILM seem to be draping over it. If you have the whole of the retina lost and only ILM is preserved, think of measles virus as a possible etiology. Moving on to choroid, you look at the granulomas all the time. So if you have the granuloma which is large, which is single, which is yellow, and which has these blood vessels running over it, think of TB. TB is VEGF driven, so the granulomas tend to have some retinal hemorrhages, RAP, or other new vascularization on top of them. So sarcoid granulomas are very different, and they can be distinguished on imaging. The top here is TB granuloma, a large single yellow granuloma with hemorrhages on the surface. And when you do OCT through the granuloma, there are changes in the outer retina. The sarcoid granuloma at the bottom, there are multiple, discrete, small, no overlying hemorrhages, and they are mostly located in the stroma. So when you do OCT, you see these granulomas like this, not like jutting out like TB. So to conclude, imaging biomarkers are important for infectious uveitis because they may give you a clue towards possible etiology, and you may investigate in a specific direction. For example, if you think it's toxo, you may or may not do anything, but you would treat. Same is for viral. But if you are thinking of endogenous endophthalmitis, you would rather do vitrectomy, or if it's pointing towards lymphoma, you will not do TB test for that patient. You would straight away go for vitrectomy because you want to rule out or rule in lymphoma. So what is most important to me is to get the OCT done through the lesion. So whenever you find an active lesion, whether it is retinitis or choroiditis, the maximum information will come when you have the OCT line scan through the lesion and correlate it with multimodal images. That's very important. Thank you very much once again for giving me.
Thank you. So I think we have heard from all the speakers for the session, and you're going now? Okay. Thanks. So we will continue with the panel discussion. As we promised, we'll keep a lot of time for us to discuss, and I'm sure by this time you would have started thinking about the questions. If you heard the spectrum of talk from the simple fundamentals imaging, then some advanced imaging, some futuristic imaging, some image analysis, and of course this beautiful presentation by Dr. Vishali. So we invite audience to come up with the questions in case if you have any. Anyone? Yeah, please go ahead to the mic. Yeah, please use the mic to ask questions.
So the change in pattern of lesions, is it according to the organism, virulence and the affinity to the tissue, or it's specific for the particular disease?
Very interesting and very thoughtful. Hopefully Dr. Vishali should have been there, and she left us in between to answer this thing. But yeah, so there are many factors, including the number one is whether it is the organism or the insult or whatever the stimulus resulting into that, and different things can cause, and then it can result. But the important thing which we need to also consider is also depends on the host immune mechanism, and that can result into the variations in the same. So I will give you a very good example in which someone need to think about because you can't treat imaging in isolation. So the serpiginous choroiditis which we see in this part of the world in India, whereas against a serpiginous kind of lesion which we see in US and all, both are completely different. When you look at the lesion, everything looks same, but one is autoimmune, and here we treat that as a TB related thing. So that way you can imagine how the host interact with the stimulus in a very different way, but in the end presenting is that. So there is no absolute answer to it, but I will say as a take home message for most of the ophthalmologists, take into consideration some of these imaging findings, but also put together the entire patient picture and epidemiology and other things before you take a call about saying that this particular sign of imaging is infective, non-infective, active, inactive, progressive, and all those things. So hope it answers your query.
Okay. Second query, we had recently 23-year-old male presented with sudden loss of vision for a few days, and there is a retinal vasculitis, and later patient developed some few vitreous cells. We did all the investigations, we did the fever profile also, because the patient gave the vague history of Cori fever for a few days back. Then it's turned out to be a scrub typhus.
Scrub typhus.
So that is another thing just want to share.
No, this is again very correct. It just gives you about some kind of a thing, but it's not that you do an imaging, it will tell you scrub typhus and all those things. You know, it just gives you some insight, but not absolute confirmatory that you do a OCT and it will get a diagnosis of scrub typhus, or you do an FFA and you will see. It will be very, very difficult to have one particular sign labeled with one particular entity. I agree. So specificity will be lacking.
Yeah.
Sensitivity might be there, but specificity will be lacking.
Thank you.
Go ahead, please.
I have a question about the vitreous haze, because would that affect the image quality for AI analysis or even your metabolic imaging?
So vitreous haze came out initially from the late Dr. Robert Nussenblatt, who developed that haze score. And when we talk about vitreous haze, one should really see how haze is obtained. To define that haze would go from 0 to 4. One require it to be examined in a certain way with this aspect and discussed about the haze over the optic nerve and things. So it is the parameter that the FDA, it was the first parameter that the FDA used to assess response to treatment. But as we know, and as you alluded to, it's very difficult. It depends on the situation of that. And on top of that, there's a difficulty because images taken from the wide angle versus the images taken from the, let's say, the Zeiss camera are different. The original work by Dr. Nessenblatt was based on the Zeiss 7-field camera. That was the work. As we know, the wide angle system, the optos, it does everything it can to eliminate the haze. So when you see in that, you cannot submit a picture from a wide angle and say that the haze coming out. So if you really want to do the haze, use the same technique to do aspect from there, take the camera from that, or the way that we do is use the 20 diopter lens looked into and then interact to the certain aspect from there. But in general, that's why haze is going out of favor. Nowadays, many of the clinical trials in uveitis not just only include haze in it, but now include other parameters that you and I and others are more familiar with and treat that.
Okay, thank you. So, while you're setting up, just wanted to ask, please come, sir. Yeah, maybe you can come.
I wonder how frequently nowadays we are considering biopsy. For example, lymph node biopsy, bronchial biopsy. I had the privilege of working with Nessenblatt.
Yes.
Bob Nessenblatt, and also Chi Chao Chan. And we used to do biopsy in so many cases, and which used to shed light in a very clear-cut way. I still remember doing few lymph node biopsy in suspected cases, especially from Asian countries and Latin America, where we suspected tuberculosis. And we could not rely, I mean, even today, we cannot rely exclusively on Manto test, which were positive in so many cases. And lymph node, wherever it was suspected strongly and no evidence of pulmonary tuberculosis. We did in few cases, and we were very happy that we did it. We clinched the diagnosis. Simply in certain cases of sarcoidosis, and every cases of vitritis where there was even small suspicion of large cell lymphoma, we had no hesitation of doing vitreous biopsy and subjecting the biopsied material vitreous biopsy in the operation room itself on the slide, because even few minutes of time can lead to busting of the large cells which we could get in the vitreous, and we could not reach any conclusion. And in my practice, even now I am doing in selected cases biopsies, and somehow I find in different places during the presentations of uveitis that biopsy hardly holds any importance. So how would you think about that?
So maybe I go first. So biopsy has its definite role, and we do biopsy in selected cases, particularly as you very rightly highlighted, intraocular lymphoma or large cell lymphoma you're saying. We do selected cases. TB can be a contentious issue, whether we do it, sarcoid and all those things. So a role, I will say the things how it has evolved, because if you think those days, whether the imaging were disposal. So this talk being a imaging, we wanted to present about the advantages of the imaging, but not to say that imaging is a substitute for some other thing. So first I will say clinical symptoms, the signs, imaging, some lab test, and if these are not able to give you the answer, then go for a biopsy or invasive procedure. So that will be my approach in the cases. We have cases once a month or once one case in 2 months, maybe something, who undergoes a vitreous biopsy and all those things. But having said that, and good thing is that the techniques for biopsy has evolved and it's becoming safe also. So it's not one of those things which people have forgotten about it. And if you go to meetings, AIOS, IUSG, people do talk about the applications of where it is needed. But I will say we try to go as less invasive as possible, just because of some of the potential complications of it. Not to say that we don't want to do it just because there are imaging tools to us. For example, toxoplasmosis, we know that it's a clinical, we do the blood test. Do we really need to do an AC tap for PCR, for getting that Goldman-Whitmer coefficient, probably if you have a clinical diagnosis, if you have imaging, if you have blood thing, you're good to treat with it. CMV retinitis, do we really need to? I used to do AC tap earlier for CMV retinitis. Nowadays, once you see CMV retinitis clinical picture and you are able to give treatment, then you know that I've seen enough clinical picture, I've got enough knowledge, and probably I no need to tap to get a confirmatory that it is that. But when you suspect, is it CMV, is it VZV, it is HSV, what it is, then you put in a needle and then you try to do a tetraplex PCR to get a confirmatory, because then you can be bit more certain. Acute retinal necrosis we always do, viral retinitis we always do. We have many EC taps which we do. CMV, endothelitis, anterior uveitis, we are doing a lot of those taps and all. Prof.
So thank you. So I'm very glad that you have a chance to work with Dr. Rosenblatt, who's in heaven right now. Dr. Chi Chao Chen has retired in the Bay Area after all these years. I think the principle that we share with our colleagues is that in managing any type of disease, especially in uveitis, when the response and when the thing is not what you expected, then we should never continue to treat the patient without proceeding to do biopsy. So that's the message that we share with our colleague, resident, fellow, everywhere, because if you expect the lesion to improve and it does not improve, you should not continue to treat that. And in the field of uveitis, and right now for that matter, we encourage a colleague to do biopsy very early. Start out with easy. One would be the anterior chamber tap, then you go to vitrectomy. But then if one eye has gotten really worse and keep getting worse, in order to preserve the other eye, we will proceed with retinal or sometimes retinal corridor biopsy, as you suggested to, and do that, and that's definitely the case in there. You mentioned a case of TB, so certainly, directly, that group, the collaborative ocular tuberculosis study, that you alluded to, does not require the patient to have lesion in the lung, as long as you have a characteristic finding in the eye and you have a quantiferon test, for example, among other possible, then you would treat it. So everything, but we fully agree with you. Biopsy should not be the last thing to do, but rather should be integrated into the whole management process, hopefully early enough that you can still save the eye and the patient.
Completely agree.
Yeah. Go ahead, please, the next question.
Thank you, the speakers, for giving very informative presentation. And I would like to ask Dr. Nguyen for two concepts about the flavoproteins. As you said that it could be a potential for like early diagnosis. So could you elaborate more like the patterns of the change, because patients could have like overlapping disease and oxidative stress causative factors. Yeah, and the second thing is about evaluate the treatment efficacy. And could you like reveal some like information or results of the non-responder versus the responders to a treatment, because a treatment may also like reduce the oxidative stress on the disease. Yeah.
Yes, so those are excellent questions. So I will admit first, the work that we're doing is very early. In fact, the slide that we're showing today, this is the first time that we've shown outside of Stanford. We've been working, this is the first type of ever work to looking for uveitis. So you're very correct. Obviously, we want to look at the change in mitochondria, and as you alluded to, the change could occur anywhere in the body. In our cases, we look for particularly in the eye to see where the changes. The pattern so far, we cannot learn of the pattern yet, but rather we want to use this as a way to tell the health of the tissue. So it's not that it's a pattern of FAF, that is more like the score and the overall, to look at that aspect from there to see whether it's early enough. Now, you also asked about management, and that's an excellent point. I mentioned to you, I showed the two cases of birdshot, and it is something that we're learning right now. In one case, from a clinical point of view, from some functional testing, we feel that disease was not under control. So we increased the dose to 40 milligram weekly, which is the highest dose that you can give for that treatment. The other case, we thought it was stable, so we would maintain it on 40 milligram every other week, which is the standard dose. Yet the FPF score was higher in the latter, we thought it was stable. So now it makes us start thinking, and and I don't know the answer yet because we still gather a lot of data, whether or not did we have enough information to call the second case a stable case, or would it add to it? And I think that's the point that you astutely referred to. This numerical thing would be useless if we cannot apply to a clinical application. So we are now integrating what we see from those score, we then see from this patient. Ideally, what we would like to see is that on a longitudinal point, can we see whether our prediction with and without FPF would be correct or not? It may turn out that in the future, we will add it to it to do. So for example, let's say Birdshot, we don't make decision based on just the FA or just OCT or the things like that. We use functional endpoint, and we overemphasize because we have to figure out how much damage that they occurred and could it be added to it, to that.
Yeah,
Thank you.
Professor.
Thank you. So, Junction, ZX, I have a practical question for you, and you're a great teacher, educator, and all. So, we've spoken about settings, which is a high-end academic settings and institutional setting. But this meeting is APO, AIOS, and there are many people, general ophthalmologists, who come, and they want to see. They might be the first people who are seeing the uveitis patient. These are the general ophthalmologists doing cataract and some glaucoma and all, not really large practice, but they are able to diagnose uveitis. So, want to see your thoughts on what are the essentials they can do besides the clinical thing. They have done all the thing clinical, but they need to do this before they think they are not able to see a patient or manage a patient and refer to a tertiary care setting which has all the fancy equipments, whatever we speak about. Or as soon as they see a patient of uveitis, because it requires imaging, they should not be the one treating. They should immediately say, okay, this is beyond me because it requires OCT, it requires FFA, it requires wide field, and cannot. Just some bit of audience, because there will be some audience who will like to take home and understand. So I think you will be the best person to advise on this thing.
I highly doubt I'm the best
No,
person, but I will try. I think at the end of the day, the imaging doesn't dictate what we do. The clinical findings and the history should dictate what imaging we do, and subsequently the imaging adds to the list of differentials and then the subsequent management. So what I'm stressing is because we have a wealth of data from a long time about how anterior uveitis acts, how intermediate uveitis reacts, how posterior uveitis reacts, and natural histories of all these diseases. So at the very base, you should do a very thorough examination of the patient to try and categorize the anatomical location of the inflammation. If you are satisfied, so there's one rule in uveitis, right? It's never anterior uveitis until you dilate the fundus and make sure nothing at the back is involved. So if you are satisfied that this is a simple case of anterior uveitis, for instance, right? I think I've heard some other talks and some other very good questions. Should you then go on to do an OCT if the patient has 6/6 vision? Should you then go on to do an angiogram just because it is part of your step-ladder approach? The answer is no, right? It doesn't serve the interest of the patient. What's more important is you speak to the patient, you say, clinically you have anterior uveitis, you have good vision, even if you have a single cyst, the management doesn't change. You're going to go on topical steroids, and the most important thing is watch closely, right? You see the patient in 1 week, the patient is improving, you are on the right track. I don't think you need additional information. The converse is also true. If you have done a good examination and you realize, okay, there is some vitreous, retrolental cells, anterior vitreous cells, you go back to the patient. I love to ask this question because I'm not a great examiner. I'm a pampered young physician who have all these tools. I ask the patient one question: do you have new onset floaters? If the patient says, yes, I see these dots, I'm almost certain this is related, this is not anterior uveitis, then I think, okay, you may need something more. And that's, I think, the takeaway for the general ophthalmologist. You have to hone your clinical skills to try. I'm not aiming for excellence, I'm aiming to keep my medical license, and I'm trying to keep out of trouble. So you hone your clinical skill to make sure that you detect the common and easy things that you can treat, and you detect the red flags where you probably have to refer it to someone else to do the OCT to the angio. For instance, like that IU example that I said. I hope that somewhat answers the question in part.
No, this is probably the best answer I could have ever expected, and this is therefore I thought I really clap you for this thing. This is amazing. So I think this is very important and probably should be the take home besides all the fancy thing and what professor said. Sorry, I missed your name. And biopsy should be one of the integrated part, and it should not be like keep till the end when you are left with no options. So there are tools beyond it. But just one of the thing is that when people are advancing their practice, general ophthalmologist and some non-Uveitis, so fundus camera and OCT have become an essential tools in the practice. And within Singapore, I have a practice which is CMB retinitis clinic. I don't have OCT there. I can refer the patient across the road to my eye clinic, but when I don't have, I feel I am kind of paralyzed because I really want to do OCT in some. But even if I'm expert, I can't see those cysts and some of the things. So I think for most of the people, OCT and this has become, and if you can learn and advance your skills in understanding some of those things, it can be helpful. OCTA, I will say probably no. FFA might be sometimes very difficult. ICG, again, one of the complex thing and all. I don't know anyone here expert on autofluorescence because that is a topic we haven't covered. Anyone want to kind of give a quick overview, 2 minutes about application of autofluorescence, because there will be some experts who will like to give. Anadi has left. Who is that? Amon will be able to give. You think so? Autofluorescence.
Well, we showed you a picture of that. That's only a concept based on absorption, and then you autofluoresce out from that, and same thing, the concept like that as well when we use the fundus protein fluorescence. But the point that we also want to stress is that, so Zhang mentioned in his talk, when you look at imaging, it should be divided between structural and functional, and that is extremely important. Here's a very practical point. As you may note, currently in the United States, there are 2 treatments that are approved for the treatment of geographic atrophy. Both of those treatments, one is anti-C3, one is anti-C5, use fundus autofluorescence as a marker of disease progression, and both anti-C3 and anti-C5 show that there is a benefit. You can slow down the progression of that. However, one of the biggest challenges why those 2 drugs have had trouble getting approval outside of the United States, including Europe, is because it has not shown a functional endpoint. So fundus autofluorescence show that it's definitely improved the way, but one of the functional endpoint, the microperimetry, did not corresponding to that. So the authority nowadays, because this drug are not cheap, so they would like to make sure that the patient also can benefit from a functional point of view. So Zhang mentioned functional point of view, for example, visual field or ERG thing like that you need to prove this aspect. So when you do a test in the patient, in addition to the OCT or the FA, you ask yourself, does this actually have an effect on how the patient function? Because that's what the payer want. They wanted something of that nature. And that's why the anti-C2 and anti-C5 have great structural improvement, but have trouble showing a functional improvement. That's why they have difficulty with that. And so therefore, I think we are striving to get a good functional endpoint to with any type of treatment we do or any type of monitoring that we do.
Thank you. I think we had a pretty good discussion related to imaging, and I'm sure there are many more questions. Keep it coming. We are all available as a Uveitis community, and all countries have a respective Uveitis societies and different societies. Please keep it. And we have an upcoming meeting in June. Please use that advantage to go to Brazil and learn. Quite a number of talks are lined up there, and a lot of efforts have gone there in Brazil on the last week of June. So if you can attend that. With that, I'd like to thank everyone for attending this talk and this different talks of imaging, and my co-chair, Professor Van, for giving all the piece of advice and wisdom to me and everyone here. Thank you so much.
Thank you.
I just wanted to invite the speakers in the front for photo.